Welcome, everyone. We're going to get started in just a few minutes, but in the meantime, as some of you are already doing, if you want to introduce yourself in the chat so we'll know who else here. Good afternoon, everyone. Thank you so much for attending today's webinar. I do see some comments in the chat that only host and panelists can see the chat. I attempted to rectify that, and unfortunately, Zoom is not cooperating, so I apologize for any inconvenience. But we are going to go ahead and get started. Just a few housekeeping tips before I introduce our speakers. We encourage you to use the Q&A box at the bottom of your screen to ask questions throughout today's presentation. If you'd like to make comments or interact, obviously with the speakers, be sure and obviously select the panelist and attendees option, and you can send a message to us. If you encounter any technical difficulties, feel free to also message, and ICCR staff will assist you. So before we begin, a little background about the Institute for Coordinated Community Response. Our mission is to work alongside rural communities to improve their collaborative systemic responses to domestic violence. We created in 2018 as a program of the Conference on Crimes Against Women. ICCR is a training and technical assistance program whose mission is to work alongside rural communities to improve their collaborative systemic responses to domestic violence. We also host monthly webinars geared towards the needs of rural practitioners. In all of our trainings, we work to center the unique needs and strengths of rural communities while providing practical skills and tools that can be immediately implemented. Although our trainings are geared towards rural needs, our trainings are relevant to any practitioner who is committed to eradicating domestic violence. So thank you for being here today and for your dedication to improving your own community's domestic violence response. You can learn more about ICCR on our website, www.instituteccr.org. And I encourage you to sign up for our e-blast to stay in loop about all the great trainings we provide throughout the year, including our roll call training series that is available for free and our e-learning courses. So I want to go ahead and introduce our speakers today. First, we have Dr. Rebecca Stone. Dr. Stone is an assistant professor at Suffolk University in the Department of Sociology and Criminal Justice. Dr. Stone is an interdisciplinary scholar in the areas of criminal justice and public health with a focus on justice-involved women. She's developed expertise in community-engaged qualitative research methods, including in-depth interviewing, focus groups, and field observations. In addition to her work on health and justice issues, Dr. Stone is the co-principal investigator of 2 National Science Foundation Awards to develop and evaluate science communication workshops to early career researchers. For more information about her research, teaching, and public engagement activities, please visit her website, RebeccaJStone.com. Also today we have Dianne Kinney. Dianne graduated with a master's in counseling psychology and a concentration in trauma studies in 2004. She began her career in social services in 1987 in the field of domestic violence, where she has served as a medical advocate, volunteer coordinator, children's program coordinator, training and education coordinator, and an assistant director. Dianne has educated law enforcement, healthcare, and social service professionals on the issues of interpersonal violence. She has worked as a therapist in private practice and as director of residential services, where she had an opportunity to implement a trauma-informed approach to working with children and adolescents. In August of 2015, Dianne moved to Vermont and returned to her passion for working with victim survivors of domestic violence. She became the shelter coordinator at Circle, where she focused on implementing a trauma-informed approach to working with adults and children utilizing Circle services. In July of 2017, due to the retirement of longtime co-director Meg Kuhner, Dianne took on the task of co-director at Circle. In 2018, Dianne was granted a fellowship in the Robert Woods Johnson Foundation Interdisciplinary Research Leadership Program. And from 2018 to 2021, she and her teammates, researchers from Boston University and Suffolk University, completed a research project looking at the interaction of IPV and opioid use disorder, which we're going to hear more about today. So ladies, thank you so much for being here, and take it away.
Thank you so much, Lacey, and thank you for inviting us to present to you today for the great introduction. I'm Rebecca. As Lacey mentioned, I'm presenting today with Dianne, who is right over there. I believe we both use she, her pronouns, and we're happy to answer any questions you have as we go along. So please feel free to post your question in the Q&A window. Lacey will let me know. She's going to monitor the chat and the Q&A because I get really carried away when I'm talking about this project, and it's hard to track the chat as well. I just think this is such important work. I'm so excited to see the breadth of folks who are on the webinar today. I'm watching everyone introduce themselves, and I just want to thank you all for your interest in this topic and for the work that you do, because I love doing the research side. I love being helpful in the ways that I can, but it's all of you who are out there actually directly interacting with folks and changing their lives. So I'm just forever grateful for the work that you do. And if there's any way that I can be of assistance on the research side of things, I hope to do that. So I'm going to share my screen as we do, and I have some slides for you. Hopefully you like them, and I'll talk about our project. Let's see. Share my screen. All right, hopefully you can see my slides there. Someone give me a nod if they are up. Awesome, okay. So as I mentioned, and as Lacey mentioned, we did this research project in rural Vermont on the intersection between intimate partner violence and particularly in Vermont opioid use disorder, because that is what the struggle has been for the last decade or so. But I would say that a lot of what we took away from this research is probably broadly applicable to other kinds of substance use disorders. I know in Texas, particularly on the west side of Texas, there is actually higher rates of methamphetamine than of opioids. I think that there is still a lot of worthwhile information that you can take from our study, even though it was on opioids. So Dianne and I are presenting today, obviously, but I do want to acknowledge that our research involved Emily Rothman, who's in the School of Public Health at Boston University and was fantastic on this project, our amazing research assistant, Julia Campbell, and Nafisa Halim, who is a global health scholar as well. So they're not with us today, but they definitely deserve a shout out. So the project we're talking about today was supported by the Robert Wood Johnson Foundation, which is a philanthropic organization that funds a lot of public health research, especially research that informs action. So if you have the opportunity to perhaps partner with a researcher in some way, I strongly recommend looking into their various funding streams. I can't say enough about our experience with the program. So they have something called the Interdisciplinary Research Leaders Program, which brings together interdisciplinary teams like ours. So in our case, Emily from public health, me from criminal justice, and Dianne as our community partner. And so their focus is really on bringing together these teams to advance what they call a culture of health, which means focusing on these 4 action areas to promote population health and well-being. And I would say they're increasingly interested in rural communities and in issues of violence prevention and supporting folks who are in those situations. So definitely check them out. I'd be happy to answer any questions about that program as well. So when we entered the program in 2018, their focus was specifically on improving health and health services in rural communities. And Vermont is really rural. I don't know about you, but it wasn't the first place that I used to think of when I thought of rural America. But actually, some of our New England states have the highest proportions of residents living in rural places. So in Vermont, that's almost 2/3 of the population. As you can see on the map, outside of a handful of major cities and towns, or really maybe like one major city and a bunch of towns, the rest of the state has fairly low population density. And then it's also quite mountainous and of course, really cold. They have what they call mud season, where like a lot of the roads are pretty much impossible. Not impossible, impossible. And that means that things like transportation can be a challenge, as well as internet and phone access. As we know, a lot of rural America lacks access to things like reliable broadband internet, which can make things like video conferencing a lot more challenging than it might be in more densely populated areas. So our work was based in Washington County, although I think that the issues that we're tackling occur statewide. Washington County is located right here in central Vermont and is home to the state capital of Montpelier, the least populous state capital in the US, and the only state capital without a McDonald's, the claim to fame. This is not a wealthy area. The median income for a household in the city is about $37,000, and the median income is significantly lower for women. It's only about $29,000. So we're not talking about a particularly well-resourced or wealthy area. Over the past decade, as many of you may be familiar, the Northeast, which includes Vermont, has been particularly hard hit by the ongoing opioid crisis. So it was one of the first states to really ring the alarm about the increase in opioid use disorder and related mortality. And unfortunately, despite a lot of good efforts by the state and nonprofits and all sorts of hands on deck, the rate of opioid-related deaths has continued to rise pretty much year over year. And while this may have started with prescription opioid misuse back in like the 2010s, that is not what is driving the deaths today. It's synthetic opioids like fentanyl, which are far more deadly in smaller doses and have contaminated much of the drug supply, including drugs other than opioids. So, for example, fentanyl is like in the cocaine supply. Fentanyl may be pressed into pills that look like prescription opioids. So people think they're getting maybe an OxyContin pill, but it has a significant amount of fentanyl. So it's just an extremely dangerous time to be buying street drugs because so much of the drug supply is contaminated, and we are seeing so many deaths, as are so many places around the country. It is perhaps unsurprising to folks that the rate of opioid deaths increased sharply during the pandemic, when many people were really stressed out, sad, and importantly, isolated. People were using alone, and that's really dangerous. When there also may have been a reduction in service availability as service providers adjusted to working from home and also tried to navigate COVID restrictions and keep themselves and their families safe, which is not a negative comment about those service providers who really went all out to continue their work in these extraordinary circumstances, but just a sad fact that services may have been even more difficult to find for the last couple of years. And at the same time, Vermont, like probably all states, struggles with high rates of intimate partner or domestic violence. And this also increased during the pandemic. There's been a lot of chatter about this in criminal justice circles about the impact of COVID and also our response to COVID. So there's evidence to suggest that across the US, calls to police and advocates hotlines increased during COVID isolation. And judging by what we hear from advocates today, this has not really returned to normal. So we're still seeing really sustained, I would say, sustained levels of calls to hotlines and needs for service that are really sometimes outpacing the resources that are available in our community organizations, which leads me to Dianne and her work with Circle. Dianne, do you want to talk about what Circle is and the needs you meet in your community and what you've seen lately? And then we'll talk about the CCR on the next slide.
Absolutely. Thanks, Rebecca, and thanks to everyone who has tuned in here for having us. Circle is Washington County's domestic and sexual violence agency. We are in the center of Vermont. Our county has about 60,000 people, maybe a little bit less. We receive about 400 to 450 hotline calls per month for less than 60,000 people. We are one of about 15, 16 domestic and sexual violence agencies in our state. And we work, interact with those folks all the time. We have a shelter, which is a congregate shelter, meaning a big house, 6 bedrooms. Moms and kids share a room. And then there's community space for kitchen and all that kind of stuff. We are full almost all of the time. Our housing needs are ridiculous. There is no housing. I don't know if that is something that folks are dealing with in Texas as well or across the country. I think that it is, but it's very acute in Vermont right now. We used to be able to house folks for maybe 6 months, 8 months, and they would be able to find an apartment and secure safe housing. Now we're up to a year and a half where people in our shelter, which means that we can't bring new folks that are fleeing violence into shelter. So it's just a ripple effect. We also go to court with folks for what we call in Vermont relief from abuse orders, what everybody else calls a protection order. And we also help with criminal hearings in case someone is needing to navigate that system, which is really difficult for a victim. So we support folks when they're doing that. Just to talk a little bit about the increase in violence. During the very first months of the pandemic, in Washington County, the numbers of criminal complaints, the times that the police went to houses, it doubled for March, April, and May. What I've talked to the state's attorney and to the police chief, and what we think happened is because everyone was at home, people were calling the police that heard what was going on. Because during those months, our hotline was not ringing, which means that people are at home, unable to call because the abusive person is with them. But we did notice a humongous uptick. It has leveled off somewhat now, but the thing that has remained is the level of violence that is being experienced by folks has really gone through the roof and continues to do so. Did I miss anything, Rebecca?
No, I think that's all really true. Yeah, we had talked about this issue of the heightened violence. There were also sort of issues in, I think, the police adjusting to COVID restrictions and the way that they were able to respond. So it was really, and then the courts were really backed up, and I think are still really backed up. So
the courts are still completely backed up. And one of the things that happened during COVID and is still happening is folks are not being held.
that's right.
There's bail almost immediately, or just held with conditions. And that really impacts whether or not someone can get safe.
Yeah. And then do you want to mention, did we have a question, Lacey, or are we good?
You are good. Thank you.
Okay, awesome. The coordinated community response team, which you are on or lead or?
Yes, so I chair the coordinated community response. I believe this is one of the best things that we do. We bring together every month folks across our county. So advocates, state's attorney's office, the victim assistance in the state's attorney's office, our county hospital, primary care providers, pediatric providers, the health department, mental health services, substance abuse treatment providers, and recovery coaches. Local and state police. Like I said, we have about 60,000 people in our county, but that also includes 5 different police departments and Vermont State Police. So all of those folks are invited. Now, they all don't join at the same time, but they do join frequently, and it is a way that we can access them right away. Also, Department of Corrections and the housing folks. Also, what I forgot was our interfaith community also is represented.
Yeah.
And as well as the community justice centers. So it's during pandemic, it was a way for everyone in the county to get together once a month and talk about how services were being provided, what changes were being made, how we could help each other to figure out how to provide services. It was an integral part of us getting through that time.
And it sounds like from talking to providers too, this is unrelated, but it was just really like a lifeline to stay connected with people too. In a time when everyone had returned home, it was nice to see each other and get to talk.
Yes, absolutely. It was regularly, everybody still says it's their favorite meeting of the month.
Yeah, because they get to hang out with you. So going into this, we all knew, this is not brand new information, especially to anyone who's actually doing this work as an advocate or a practitioner, but we knew that there is this bidirectional and synergistic relationship between substance use and partner violence. And by synergistic, I mean that they combine to form a greater sum of their parts, in a sense, although in this case, they make each other worse, right? So the relationship between them is one that exacerbates both, right? So in one direction, substance use can exacerbate intimate partner violence. So not cause it, we're not writing off the way that one partner would abuse another because of their substance use. It's obviously a lot more complicated than that. But some substances may cause aggression and irritability or increase the likelihood of paranoia, which then exacerbates controlling behavior around a partner's behavior, or worsen impulse control problems. So research suggests that couples in which one partner has a substance use disorder may be prone to higher levels of conflict about money, about the substance use, or other relationship issues. But this relationship can also go back the other way, right? So where partner violence exacerbates substance use. So as I'm sure everyone on this call knows, intimate partner violence victimization can cause both physical and emotional pain, which victims may self-medicate with substance use. You know, we talk to people who did not have a substance use disorder before they had been in violent relationships because they were physically injured and ended up on perhaps opioid painkillers because of that abuse. So victimization can also be related to post-traumatic stress syndrome, which is associated with increased substance use. And finally, one thing that I don't think we talk enough about, I think we really need more research on this topic, is that substance use can be a feature of controlling relationships where a partner exerts control over the other by coercing them to use drugs more often or in larger amounts than they want to, or prevents them from entering treatment, or uses the stigma associated with substance use as a lever to control them, right? Like, you can't leave me or I will tell everyone what you've been doing, or I will report you to the police for the things that you've done. And so I think we are just in the beginning of having some research on this topic, even though I would say it's well known to advocates. Dianne, I saw you nodding along.
I just wanted to two other points.
Yeah.
Someone who is using a substance is absolutely less safe.
Mm-hmm.
So if you are medicating in order to manage pain, in order to stay sane, you are not able to keep yourself as safe. The other part is that often an abuser will increase or keep someone using in order to maintain the control. So it goes both ways.
Yes, absolutely. We had, I believe, someone in our study who talked about their partner controlling access to their opioid medication as a way of keeping them dependent, and also, you know, potentially causing them pain if they withheld it. So
it's also another way to help people to not want to involve police.
Yes, 100%, right? Because, and this is exactly, you know, one of the challenges in getting people the help that they need is this fear of law enforcement involvement. So to tackle these related issues, Dianne had seen this in her community, had situations like this with circle clients. So to tackle this, we launched what we call a community-based participatory research project. So the difference perhaps between what you might think of when you think about research is that this approach really involves researchers and community partners on equal footing, centering the needs of the community, you know, perhaps rather than the researcher doing science. It's about what does this community need, and producing research results that are translated into action. So again, this isn't just about like publishing reports. We want to do something, typically to improve health outcomes. This is very common in public health research, although it certainly has been used in other fields as well. So we decided that our study would have these 3 phases. First, we wanted to do a needs assessment to really understand the needs of people who had experienced both partner violence and opioid use. Then we wanted to take that information and come up with something we could do, right, to meet those needs. We didn't want to just take information from people and then go on our merry way. And then finally, we wanted to check and see if that intervention actually worked, so to evaluate it. And this was all overseen by our expert advisory board, pictured here, of people with lived experience. So this is Lisa, Liz, Hillary, and Kat. And I wanted to shout out to them because we're so grateful for their guidance. They're just the best people in the world, just so wonderful. And they were so helpful on the project. And importantly, we paid them for their time because experts deserve to be paid. And these people are subject matter experts. So we were happy to build that into the grant. And I would advise anyone else out there considering doing work like this to not be extractive of people when you're asking them to share their experience, because that is expertise that they have. So here is the overall design of our study. As I mentioned, it has these 3 phases: the in-depth interviews with survivors and stakeholders, and then working directly with the community to create some sort of intervention. We weren't sure what it would be at the beginning. We had some ideas, but we wanted to really make sure it was grounded in what would be feasible and desired by the community. And then actually doing the thing and getting a sense of how it worked. And as you can see, the pandemic dropped like in the middle of all of this, which of course complicated this whole plan, but I think we still pulled it off in a way that was meaningful and had impact. I know there are a million other things that we wanted to do, but we managed to do a lot of it online. So the first step was this qualitative piece, so in-depth interviewing. We recruited 33 rural Vermont residents with lived experience of partner violence and opioid use. And we did this through circles, contacts, through our advisory board, flyers at the offices of service providers, and through then referrals. So if we talk to someone, we'd say, do you know anyone else who you think we should talk to, and they might pass our information along. We published this article in the Journal of Rural Health, and I'm going to send a copy of it to Lacey after this call so she can post it with the webinar if you would like to read it. It's not too bad. It's only about 10 pages. We tried to not be too nerdy in there, but I am going to talk about the results of it now too, so you get the high points. So in our interviews with rural residents, in this paper, we identified 5 major themes relating to their experiences, and I've combined them into just 4 here so that I could fit them on my slide. But the first, which is probably familiar to any of you working in rural spaces, is the geographic isolation in rural Vermont. So our participants often lived outside of town and relied on personal vehicles to access grocery stores, pharmacies, treatment providers, which may be many miles away. They did not have good access to public transportation, and if they didn't have their own reliable personal vehicle, or if their partner controlled vehicle access, they were quite literally stuck, right? One person talked to us about living down at the end of a dirt road, and when her partner would leave the house, he would take the jackets and the boots so that she and her young children could not walk the couple of miles to the nearest town. So this is quite literally isolation in all of its terms. This also means that neighbors are not able to report the offense, right? As Dianne mentioned, one of the explanations we have for the increase in police calls during the pandemic and not in hotline calls is that may have been bystander intervention of people hearing the violence or becoming aware of the violence and calling the police on behalf of the victim. If you're very geographically isolated, the chances that you encounter helpful neighbors like that are lower, right? Related to this was the social isolation of not just living in remote areas, but also the nature of partner violence and substance use. So first, our participants reported that they were isolated through their experience of abuse. So when you have a jealous and controlling partner, they may limit your contact with friends and family. So they spoke about their partners going through their phones, not wanting them to be with friends or family, talking negatively about their friends and family to further isolate them, which of course is another lever for control. This also prevented them from reaching out to someone for help or from other people spending time with them and noticing that something was going on with them. but they were also isolated by the stigma of the substance use. So histories of substance use had left many people estranged from their friends and family, and also fearful that if they did seek help, they would be more likely to be punished than to be supported. So if they did try to go to the police station and say, I am in this situation, they were scared that they'd be more likely to be arrested on outstanding warrants or to be drug tested or face these other kinds of punitive interventions.
Dr. Stone, we do,
Oh, yes.
I'm sorry, we do have one question. Someone
Yeah.
wanted to know what the fifth theme was.
Oh, so I've combined two of them here. One was inappropriate services and one was inaccessible services. So I'm going to talk about both of them, if that is okay. We broke them out separately in the paper, which is why there were 5. So combining those two themes here, actually, we also found that people encountered inappropriate or inaccessible services. So we'll talk about the access issue first. If services existed in their area and people were aware of them, which was not always a given, they were not always accessible to our participants. So for example, some emergency shelters would not allow women to stay with their children, right? That makes them inaccessible to someone who is trying to leave a violent situation. As one woman explained, like, what am I going to do? Make the kids sleep in the car while I go inside? Like, no, we're not going to do that. So sometimes they were shuffling around, like trying to place children with friends so they could go to the shelter. It was just a barrier to safety. If a service is located off a public transportation route and has no other transportation options, that is inaccessible. We saw telehealth services expand in the pandemic, which a lot of folks are touting as like, great, we should further expand these. But in remote Vermont towns, it can be difficult to maintain cell phone or video conference connections. So we had some folks who were walking into town to go to the corner store to use the phone there, right, to call in for their appointments because they did not get reception where they were living. And finally, while there's some amount of stigma associated with both partner violence and substance use in towns of all sizes, residents of small towns felt extremely visible. So they were the subject of local gossip mills and felt very conspicuous when they were struggling or when they sought help. Like if people driving by the methadone clinic could recognize their vehicle parked outside. So this connects to the reality that there's very little dignity in substance use treatment options in a way that we do not see in other types of medical care, right? We do not make dialysis patients line up outside in the morning to get their treatment. We make methadone patients do that. So making people line up for their methadone dose or sit in crowded waiting rooms, waiting for their turn, made their struggles very public, which in a small town felt, was a huge disincentive, right, to go through this. One of the local treatment providers ran a special bus to get people to the clinic, but it often left really early in the morning, which like 4 in the morning to go start and do this lap. But also it's stigmatizing, right? So one of our advisory board members called it the junkie short bus, right? Everyone knows that everyone on that bus is going to the methadone clinic. It's not something you want to take your kids on if you are, responsible for them during the day. It's not appropriate or accessible. And there's a lot of dehumanizing kind of aspects to just trying to take care of yourself and do what you think you're supposed to do. So these were all issues that were raised by folks in our interviews and things that we knew we needed to address with some sort of intervention. It's like the pandemic all over again. Why? So I'm sorry. After analyzing the interviews and identifying these themes, we organized an all-day working meeting for essentially an expanded CCR team. So we invited our advisory board members and representatives from many different health and human service agencies. Here you can see, we have advisory board member Lisa, who's here with the scarf, talking to a gentleman who runs a substance use support group organization and recovery coaching organization. And then I believe she's actually talking here to the head of the Department of Public Health. So a very mixed table. Over here we have Dianne. I believe she's sitting next to someone who works with economic services.
DCF, Department of Children and Families.
DCF, thank you. So we assigned seating because I'm a professor and I get to do that. We assigned people seating so that they had to mix it up, right? We had tried to have a member of our advisory board at each table, and then a member of our research team, as well as these folks from all of these different human services agencies. It was really fun. We started off with an asset mapping activity to help everyone recognize the background, experiences, skills, and passions that they brought to this issue. And this was really important because one of the first things that happened this day was we sat everyone down at the table, so doing the asset mapping, and Lisa from the advisory board called me over and she was like, I don't know what I'm doing at this table. Like, I don't have advanced degrees. I don't have the work history of the people here. And I was like, Lisa, you are the star of the show. Like, you are the expert. You are the person who's actually been through this and tried to use, I'm sorry, one moment, tried to use these services.
Speaking of working from home.
It's great. Super professional. Thank you. Sorry, my children are just coming home from school. So Lisa did not understand or didn't have the confidence to be the expert that she is. And this activity totally changed her, right? Like the next time I walked her through this, this is the goal of this activity. The next time I turned around, she was deep in conversation with all the folks at her table. And then she spoke out during the group discussions. And it was just really a confidence builder for her and crucial to making sure that she was an equal participant in the event. So I strongly recommend doing something like this if you're having an event that has mixed participants like this, because it's really important to understand that we all bring something to the table. So we had taken our interview data and turned it into what we called illustrations. And we did this because we didn't want to tell any one person's story for two reasons. So first, in a small community, this information could be identifying, right? So you don't want to just tell someone's whole story because even without names or specific places, that could ring a bell. But second, this was not about any one person's story. We need to not individualize this issue. These were widespread experiences. So we presented the themes that we saw cut across our 33 interviews. These were, while every story was unique, these were the cross-cutting ideas. So we gave each table one of these illustrations, and we asked them to identify what we called pain points, or areas where services were not meeting people's needs, right? So where are the gaps? What would have helped this person? What could we have done better? We collected all the pain points onto a flipboard, and over the lunch break, you have to feed people. That's not negotiable. We fed them. Over the lunch break, we invited folks to turn the pain points into how might we questions to identify opportunities for intervention. So rather than focusing on those deficits and gaps, we turn the questions into opportunities for closing them. So for example, here we see that a group had identified isolation as a pain point, so geographic and social isolation. And underneath it, someone, might be my handwriting, I'm not sure, has written, how might we promote positive social connections while keeping survivors or those in recovery safe from social networks that may harm their path to recovery or safety. So for example, past acquaintances and things like that, who sometimes can trigger relapse or drag people back into lifestyles they're trying to leave. So this was an important activity to move us to our next point, which was timed brainstorming. So these were timed brainstorming activities to generate as many ideas as possible to address the most common questions that people had put on our papers. So here's Dianne at a table with our advisory board member, Kat, over here, and some other folks who work in, I forget, there was DCF, and Anne works in, I believe, sexual assault survivor advocacy. So again, another mixed table, and these post-it notes all over the table are ideas. There's an idea on, at least one idea on each of these Post-it notes that was sort of part of the rapid brainstorming with possible interventions or solutions. So as you can imagine, I actually have these Post-it notes in my closet still. There were hundreds of them. They are just sitting in a bag. But this activity raised a lot of really great ideas. So then we kind of pulled them to see what was floating to the top, what were some of the ideas that people were coming up with at multiple tables. And we had folks give a commitment to action at the end. So a lot of the ideas that came up, people were able to take back to their agencies themselves and commit to working on. So this activity raised a lot of great ideas, mostly around, the highest priority interventions, transportation, housing, especially recovery housing. There are fewer recovery houses than, sort of when you think of it proportionately, there are fewer recovery houses for women than there is, women as a proportion of people in need of recovery housing in Vermont. So they're sort of underserved, right, in terms of their representation. People had talked about gender-specific support groups. So women particularly who are experiencing substance use disorder do not want to go to a support group and be hit on, right? Or like some gentlemen in the support group trying to date them. And they may want to talk about, specifically gendered experiences. And so having gender-specific support groups was something that people expressed a need for. So of these, we thought that it was most feasible for us, on one hand, to address the housing issue or recovery housing, and we'll talk about that in a moment. But specifically, as like a research community team, we thought we could address this cross-training piece, something to inform the recovery workforce about partner violence and to inform the partner violence workforce about substance use disorder and recovery. So focusing on those pieces first, we worked with Circle and with Recovery Vermont, which is an organization that trains peer recovery coaches, and developed a cross-training workshop, an all-day cross-training workshop that we held online because it was the pandemic. But we wanted IPV advocates to be better informed about what substance use disorder looks like, what it's like to have substance use disorder, and what recovery looks like as well, and ways to support people who are in recovery. And then we wanted peer recovery coaches to be better informed about intimate partner violence, so that if they were coaching someone and they were concerned about the nature of their relationship, or if someone disclosed to them, they would at least be aware of resources and maybe what to say and what not to say that would be helpful. So on the day of this training, we had a morning welcome session where we brought everyone together. We did the asset mapping activity again in small groups. And then we split our 40 participants into 2 sessions for specialized training. So our recovery coaches went to a session with Dianne about intimate partner violence, what that looks like, power and control, specific Vermont mandatory reporting laws, RFA, the process to get a protection order, and of course, resources like Circle and who to call. And our advocates went to recovery coaching, where they got sort of a Substances 101 crash course, information about what recovery coaches do, and also information about resources and what to say and what not to say, and essentially the nature of substance use disorder and recovery. And then they went to lunch, and then we brought them back after lunch for information about, of course, the relationship between these 2 issues. We shared the results of our research and what people were experiencing. And then we also did brainstorm activities with this group. For example, we use these Google Jam boards that are really cool. They're like a virtual whiteboard. You can draw on them. You can generate sticky notes. Just a great way to do online what you might do in a physical workshop. But we use them to generate feedback about the training, feelings and questions about it, and also what they could do next, what their next steps would be. And we'll talk about that in just a moment. But here is a photo of our amazing group used with their permission. This was just a wonderful day. My power went out in the middle of it. It was great. I had to quickly run to campus to pick up and carry on. But everyone there, I mean, it's sort of like the folks in this webinar, just so committed and so caring, and with such expertise and experience. It was just a privilege to be a part of it. So the we collected pre and post data about the training workshop, and I won't dwell too long on the data. We have a publication about this. I would also be happy to share with anyone who is interested in it. But I just want to point out a couple of important changes. So this is the survey of the domestic violence advocates pre and post training. So you can see before the training, about 28% of the respondents felt confident about their ability to address a client's alcohol or drug use, and afterwards 71% said they felt confident about that. So that's a nice improvement to see. And among the recovery coaches, we saw big gains in confidence about addressing a client's domestic violence victimization or perpetration. So these are these two columns here. So increases from 47% to 88% and 27% to 81%, as well as with working with a client who chooses to remain in a violent relationship, because it was sort of news to some of our recovery coaches that leaving may not always be the safest thing or what you should strongly recommend. You really need to meet a person where they're at and to trust their assessment of their own situation. And so that was an important piece of what we really wanted to communicate. And I was glad to see the change pre and post workshop with our recovery coaches there. The workshop was well received across the board. Participants felt it addressed a need in their community, but they did want a part 2 for more advanced information. Especially the advocates wanted a part 2 about substance use and more about maybe specific substances. The recovery coaches specifically benefited from the information about domestic violence. As you can see down here, Dianne, do you want to talk more about the feedback that you heard from the advocates about their experiences?
Surely. The advocates were pretty surprised that many of the recovery coaches started talking about their own experiences of violence within the groups, because we brought them, broke them into small groups during the training, and they all were speaking about their own experiences. And I think it was news to the recovery coaches that they all had a very similar experience of IPV. So this in itself was a huge awakening for lots of folks. And the IPV advocates really were clear that they needed more information, a deeper dive into substance abuse. But we're very pleased, and both organizations or both groups of people felt much more comfortable referring to the other, which was our goal.
Yeah, I think one of the biggest things, regardless of running the training or thing like that, was just building connection. Because I think sometimes when you're deep in the trenches doing this work, you're not even aware of perhaps other organizations with specific skill sets, or that you could refer to, or that you could potentially form collaborative partnerships with. So even if the training had not had an impact sort of on people's confidence or knowledge, just getting people together in a room was already capacity building, right? Like forming those relationships.
Well, and the other thing that we discovered is that many advocates believe that recovery coaches might come to the problem differently than, so as IPV advocates, we meet somebody where they are, we talk to them about what they need, and and many of us were under the false impression that recovery coaches were going to be coming at it from you have to stop all, you have to cold turkey, sober, What we found out is that mostly everyone's talking about harm reduction now, which is great. And that we both use a very similar type of intervention, in that we call it empowerment counseling. They talk about, what is the word, Rebecca?
Motivational interviewing.
Thank you, motivational interviewing.
They were all about motivational interviewing.
Both of those things are grounded in exactly the same ideas. So that as soon as both the recovery coaches and the advocates kind of figured that out, it made it very easy for everyone to talk and to support each other. Yeah, it was a really good day.
Yeah, same work, different subject or something, but very similar role.
Just different language, different ways to categorize it, that's all.
Yeah. And so I'm going to lean on you again then to talk about what has happened since then, because that's almost more exciting.
So we have been so thrilled. I have been personally thrilled. I have wanted to, since working in my first shelter in 1987, I knew about the intersection between these two issues and the complication of how difficult it makes for someone to address either issue. So being able to do this and work on this project was a dream come true. The bus stop that Rebecca talked about that would go almost to where folks could get MAT treatment. Literally, it was like a mile. They still had to walk a mile, and and it was a heavily traveled road where everybody that was driving to work could see all of these addicts walking. And it was just really demeaning. Before we did our day of getting everyone together, one of the treatment folks had said to me, "Can I call and see if we can get this changed?" I'm like, "Absolutely, please do." And she single-handedly was able to talk to them and get them to make the bus go further. It took, a couple of months, but that was before we even did our research. And I think that's the power of people having information. One of the other things that happened was our statewide entity, the Vermont Network Against Domestic Violence, was able to get some funding so that advocates can go through recovery coach training. So the way we addressed the advocates' wish for deeper dive and a bigger understanding of substance abuse is that they are now going through recovery coach training where they can do that. So right now, 3 of the folks that work in my agency, and there's only 10 of us total, are trained as a recovery coach. Almost every agency in Vermont that is an IPV SV agency has at least one person trained as a recovery coach, which is fantastic. The other thing that has occurred is that in Barre, in the town that we work in, because of this work that we did, we worked with a housing agency who was able to buy a house and get the recovery community to agree. We now have Foundation House, which is a recovery residence for women that they can bring their kids in, which makes the 3rd one in the state of Vermont. I was able to work with them really closely to figure out how they could incorporate kids into the house. One of the things that the folks who run the recovery communities, they were like, we've never had kids in our house. What do we do? And I'm like, we always have kids in our house. So I shared all of our policies and procedures and everything. And that just opened in January 2023. So that was just fantastic. There's also increased presence of advocates on all the statewide task force. I've been working with folks with a HRSA grant. It's much more known in Vermont that these two issues intricately connect. And Rebecca and I continue to work together, and her students from her IPV class have created all kinds of projects for us because, like I said, there's 10 of us. So we're all doing advocacy. So trying to make really fun and beautiful informational products is not something we have time to do. So our teaming together has been very, very fruitful.
Yes, I have many students to put to work. And they're only too happy to, right? Because I don't know if there are any other professors or instructors on this call, but this is an excellent way to get students working on real world problems and doing things that really matter. And it's so much more engaging for them to make a product for an agency like Circle than just something that's going to stay within the class and only their professor sees. I think it really brings out a new side of students and a new level to their abilities when they know that they're making something for an organization that's doing important work. It makes them really passionate about it. So it's an excellent opportunity. I will wrap up here. Oh, yes.
Sorry, we do have a question. So
Yeah.
someone asked, curious if the children living in the recovery residences are trained in the administration and provided, and I'm not going to pronounce this correctly, it's the name of a drug, NALOXO.
Naloxone.
Thank you. We have started to discuss the need for minors to be trained, but running into a lot of personal beliefs around the thought of training youth in this.
That is super interesting. Dianne?
So training kids to be able to give
Narcan.
I think I know that there have been incidents of this happening in Vermont. I don't know as far as the kids in the house, depending on ages. You know, I'm hopefully not going to be teaching a 5-year-old to do this. And I haven't talked with them about that particular thing yet. In our shelter where we also have Narcan, the adults are told where it is and how to use it. We have not started, but most of the time our kids are like 10 and under. And yeah, that's an interesting question. I'm not sure. Yeah.
I really hadn't thought about that before, but it is fascinating. I mean, we teach children to call 911, right, and stay on the line and that sort of thing, and where minutes could count. But it is a heavy thing to think about, right? And I can understand that there are concerns. And as the person asking the question mentioned, we run into deep ideological barriers, right? Like, is this so different than teaching other forms of emergency response? Not really, but we feel like it's different, I think, sometimes. So I will wrap up here and be happy to take more questions, but essentially,
we had one more comment after that. I'm
yeah.
sorry. So someone just commented, unfortunately, teaching a child how to use Narcan isn't a lot different than teaching them to call 911, which you mentioned, because some of them may not even have access to a phone. And then someone also mentioned in the chat, we teach them to use an EpiPen, but it goes to the bias we have with substance use disorders.
Yeah, it definitely could. No, I think these are great points. I would love to have more conversation about this with, you know, trainers and other service providers. My sort of concluding statements are that intimate partner violence and substance use separately are very common. These are not niche things. These are not rare things. They are in all of our communities, and the relationship between them is complicated, but this connection is often overlooked because our services are so siloed and everyone is trying to put out their own fires, which I get, right? Like, we are all overextended, you folks even more so, right? I have students in crisis, you have clients in crisis. This means that our services often have gaps, and we're probably not seeing or meeting the needs of maybe our most marginalized folks who need us the most. Our work also shows the power of researcher community partnerships to produce more than just research papers, but work that actually changes the situation on the ground. But that said, there is plenty of work to be done, and I'm sure that this is true in your communities too. So we continue doing it. But I think talking about it more and sharing these ideas more makes lighter work of all the work that does need to be done. So I will happily open up to discussion and questions. That's all the presentation part that I have.
Wonderful. Yeah, if you will put your questions in the chat, I had a question, and other people may be familiar, but can you speak a little more about the asset mapping, how that is done, what that looks like?
Yeah, so this was actually a teaching thing that I learned about in a book called Project-Based Learning in the First Year, which is out of some authors at Worcester Polytechnic. But this asset mapping approach is particularly helpful for people who may not feel like they belong in the room that they're in. So it was promoted. It's used in all sorts of community work, but specifically in this book, it talked about students from underrepresented groups, students who might be first generation college students. How do you reassure them that they belong, that they have assets, right? That they are an asset to the classroom, even if they may not have had the same opportunities as others who are there. So it's just a concept map looking piece of paper. I'm happy to make mine available. You can adapt it and put whatever, groupings on there you want. But I just have students or workshop participants sit and fill it out. And there are sections for things like your professional training and education, but also things like your creativity and your hobbies and where you grew up, right? Sometimes your knowledge of a geographic area is an asset, that this town in Texas really well, and the resources that are available there or the culture. And then I use it as an icebreaker. So I have people sit and fill it out, and then I have them talk to each other in their groups or at their tables. I would be happy to share the PDF of the document. It's a really great icebreaker because people will realize that they have hobbies in common, or that they're from the same town, or they've had a similar experience, and it sort of puts everyone on an equal level before the conversation begins, so that there's a lot of recognition of what everyone is bringing.
Rebecca, I think it was especially helpful with the fact that we had a lot of survivors that were also joining our group and helping them to see that, yeah, they brought a lot to the table and it was what we needed to hear. So it was very much a form that leveled the playing field for everyone, which was lovely.
Yeah, I always think about a friend of mine who had struggled with substance use disorder and homelessness. And when I think about her, I think about what an encyclopedia of knowledge she was about cobbling together the various social services, right? To an extent that I would have I know that food stamps exist. I know that WIC exists, but she could tell me the limits on each one, when you had to sign up, what your eligibility criteria were, like this multi-sector, multi-program knowledge about how to stitch it together to survive on it, that I think anyone who hasn't done that doesn't know. We might know the specifics of our program, but how does it interact with all the other programs out there? How does it not interact? Someone who's had to live on that can tell you better than an expert, I think.
Well, and one other question I had, while others may be thinking of some, is how did you engage the criminal justice system in any of this work? Like I hear a lot about on the treatment provider side, the advocacy side, or community-based advocacy, but was law enforcement or prosecution, like were there any element of the criminal justice system involved in any of the systems change talk?
Dianne, you work closely with your local chief of police, right?
Absolutely. And Department of Corrections was also part of the planning and the research. Folks in Department of Corrections actively sent us possible subjects who wanted to participate in the research. We work very, very closely with both state's attorney's office and our law enforcement. So they were very aware of what we were doing and really supportive of it, because they know that they were happy to find us looking at both of those things together, because they'd like both things to get less.
Yeah, and I think there's recognition among anyone who works with this population, and I know that I see it in my research all the time, the extent to which partner violence is a reason, particularly for women's involvement with the justice system, right?
Absolutely.
So if even when you're working with system-involved women on the offender side of things, most of the time they have been in abusive situations as children or as adults. And most of the time there is also substance use involvement, right? So this is the population that needs help.
That's wonderful. Great presentation. One last thought, knowing that turnover is very common, like, are there plans to continue the advocate, then peer recovery coach kind of cross training, or what's next?
We haven't talked about it, but I would definitely be interested in doing it. The Recovery Coach Academy has actually gone through some shifts and has new leadership. So I could talk with them to do another round. I think one of the things that's happened is the advocates for IPV and SV agencies have actively participated in recovery coach training. So it would be more so the recovery coaches that I need to catch up on.
I think one of the best parts about this training is that we essentially adapted existing training for the Circle volunteers and then existing training for the recovery coaches. And so if there's anyone on this call who is interested in doing something like this, all you really need to do is identify an advocacy organization and a recovery coach or substance use expert organization and get them to borrow pieces of their training and bring them together. And you can do it too. I won't say it's easy, but you can totally do it.
Well, the thing that's really, really great is if everyone has a coordinated community response, like with our group that has been meeting for years, and yes, the players change, but the organizations are always represented. It was really easy for me to go to them and say, we're going to do this. Please, do you want to get on board? And they were like, yeah. So having that in place made all of this possible.
We have a couple of questions that have come in. So do you start inviting vested parties to a meeting or conversation to get the conversation started on how to be more coordinated in our response?
I think it's, if you don't have a CCR, starting one is a good idea. And, inviting as many people. For up until about 3 or 4 years ago, I didn't have as many people invested. As the group has gotten larger and as people have said, oh, you need to come to this meeting. So like anybody that wants to come, please come. I don't care how many people. And unfortunately now we're still on Zoom because now it's easier for everybody to do Zoom. But I think invite people to talk, and as long as you can present to them what's going to help them. Everybody's selfish and wants to figure out a system for getting help for themselves and the folks they're working with. So if you can prove to them that it's going to work, I think, yeah, you can definitely get those people talking.
Right. And I'd like to highlight on our Institute CCR.org website, we do have previously recorded webinars, which today's webinar will also be housed under our resource library. And we do have a webinar about the basics of starting a coordinated community response in your area. So you may want to check that out. So one more question. In Wisconsin, law enforcement uses a lethality assessment to gauge the severity of the victim situation. Did you or do you use this at all when gathering this research?
So in this research, we didn't use a specific lethality assessment, but I know that Circle recently went through additional lethality assessment training and certainly know what they were. The lethality assessment wasn't key to our research this time. We did use validated survey instruments for substance use disorder assessment and for assessing, the severity of the violence people had experienced. We talked to folks who had experienced violence in the past, the past couple of years, as well as right now. So some folks were thankfully out of their situations when we talked to them and were reflecting on what they'd experienced. So we were not typically working with people who were in that dangerous of a situation. But lethality assessments are super important. And Dianne, I know you were just talking about this.
Yeah, most of the law enforcement agencies that we work with do use the lethality assessment, the LAP. We just did a huge training with the Vermont State Police to help them to use it more regularly. And that worked really well. And one of the things I was able to do was to talk with them specifically about the impact of substance abuse on IPV situations, so that that is in their brains as well. But yeah, we use that all the time.
Wonderful. Any more questions? We have a little more time. Anyone, any other questions? Someone just asked in the chat, will there be another training using the lab? Or I guess for ICCR, we have some other law enforcement type interventions planned for our March webinar that I'll go ahead and share now, but specifically the lab is not something we have currently scheduled. But we do have a couple of virtual trainings. Don't have specific dates yet, but February, we are going to have a consulting group that works in rural teen dating violence, and they're going to discuss a rural collaboration to end dating violence. It's a publication that was published in collaboration with the consultants and the Idaho Coalition Against Domestic Violence. And then in March, we are going to have John Jay College has their National Network for Safe Communities, and they are going to be highlighting their intimate partner violence intervention program, which is geared towards law enforcement specifically. And see another question, another chat. Someone just, okay. So finally, thank you ladies so much for sharing your expertise with us today. Very informative. Really appreciate you being here today. And so some questions about verification of attendance and certificate. Yes, when you close out your browser, when you end your Zoom today, your browser will populate with a survey. If you will take that survey, at the end, there will be a link where you can print out your CEU certificate. And then we want you to join our conference, the Conference on Crimes Against Women. We are in our 18th year. We're going to Dallas, Texas, May 22nd through the 25th. And we are offering participants today on the webinar a discount code that is good for 24 hours. So if you will complete your survey, your discount code will also be there, and it expires tomorrow at 3 p.m. Central Time. So go ahead and get registered and take advantage of that discount code. So I think that is all today, and we thank you again for being here. If you have any other questions, feel free to reach out, info@instituteccr.org. Thanks for your time.
Thank you for your work, everyone.
Yes, thank you for coming.